Hey everyone. Everyone in healthcare has a story that they never forget. Some are beautiful, some are difficult, but most are never told. This is the space where doctors talk about moments that changed them. Welcome to HUMED, where we talk about the emotional, moral, and human realities of medicine. I'm Dr. David Spiro. Thanks for being here. Please hit subscribe wherever you listen to your podcasts. I'm incredibly delighted to have Dr. Patrick Ayers with us today, who is a colleague and a friend and a mentee and a mentor, all kind of wrapped up in one. And Patrick grew up in Mississippi. He went to college at the University of Mississippi that finished in the Final Four, if I believe, of college football this year. Patrick is a mild fan, and that's to put it lightly. He loves going to see his Rebels. Is that it? The
That's
Rebels?
it. Yep.
Yeah, the
Ole Miss
Rebels
Rebels.
play Ole Miss Rebels, and then ended up going to medical school at the University of Mississippi Medical Center, and then also then we were fortunate enough to have him here as a pediatric resident at the University of Arkansas Medical School, and then stayed on for Pediatric Emergency Medicine Fellowship, where I met Patrick probably about 5 years ago, and then he is now a year and a half, 2.5 years, a year and a half into
Oh my
faculty.
goodness. Uh, I'm losing track, but it's 2.5. Yeah, coming up on 3 years now.
Yeah, 2.5 coming up on 3 years, which is incredible to think about. That it just seemed like you graduated yesterday. So, Patrick, honored seriously to have you on the show, and I'm delighted to have you tell your story. I've been waiting to hear a little bit about what you'd like to tell the audience.
Absolutely. David, thank you for having me on this podcast. A wonderful opportunity to just kind of take a peek behind the veil of what goes on in our day-to-day lives in the emergency department. And, when you invited me onto this podcast, I was kind of racking through my mental Rolodex of all these cases I've had in the past. And, there have been so many meaningful cases that have had major impacts on the way, not only that I practice medicine, but just how I live my life in general. Um, the one that I wanted to focus on today, I mean, kind of share with you guys, actually will resonate with you as well. It's regarding the case of the infant that was attacked by an animal at home. But the reason I picked this one was because I kind of want to focus on, how it affected my personal growth and how it helped me kind of develop a little bit of courage whenever it comes to working in the pediatric emergency department. Just to kind of give some background for those that aren't familiar with the story, this was a very tragic case that occurred regarding an infant that had been bitten by a dog, the family pet. I cannot remember the exact age, but very, very early into its infancy. And the mother was in a room with the baby in her bassinet, and the 4-year-old child was her 4-year-old son was also in the room with them. And she got up to use the restroom for less than 5 minutes. And in that room with those children was the family dog. It was a full-grown husky. And she heard her son start to scream while she was in the bathroom. And when she came out, the dog had bitten the infant's head, resulting in a very devastating, very traumatic head injury. They immediately called 911, where major heroic efforts were undertaken to stabilize this young baby, and actually got the baby on the helicopter heading towards us, since we are the major trauma center in Arkansas, pediatric trauma center in Arkansas. We all knew had to come see us. Vital signs were stable en route. I believe the baby was on multiple pressors. Lots of interventions had already been done by their surgical team at the other hospital. when the baby got to us. Baby, had decent blood pressure, heart rate, was already intubated at the outside facility, and everyone was present. Our trauma team, our neurosurgeons, everyone was at the ready to try to see what we can do to potentially save this child's life. And we knew based on the extent of the injury, we knew we had to get some imaging because the baby was too unstable there to get a head CT. And so we were able to transport the infant to our CT scanner, and unfortunately, that's where the baby died. We could see the heart rate beginning to drop and lost pulses, and we had to try to resuscitate in the CT scanner. So obviously not ideal um, place to try to run a code, but with the help of our trauma surgeon, our neurosurgeon, and just our wonderful nursing staff and everyone that was involved. We did the best we could, but as we see often in our line of work, yeah, you often see more of the bad outcomes in that situation than the good. Um, so once we had pronounced the infant, we knew the family had not yet arrived since they had to travel. In my mind, I was just kind of already thinking about, okay, what am I going to say to this family? I don't know if it's mom, dad, grandma, grandpa. I don't know who all is coming down. And of course. No one has informed them of their baby unfortunately passing in RER. And so, in my mind, I'm thinking, obviously, just like in any situation, they're holding out hope, because when they were at the other hospital, their baby was alive, and so they're holding out hope now that the baby's being transported to another hospital that specializes in this type of care, that their baby's going to be okay. And so, a couple of hours pass, and we are informed by our social worker that the family had arrived, and we had the family brought to one of our consult rooms, and was just getting things ready to go and meet with the family and discuss kind of the course of events and the unfortunate outcome of their baby passing. And I remember very, very, very distinctly. It was me and one of our trauma surgeons and the neurosurgeon. They graciously stood by to kind of be a part of the conversation, because this is just a terrible event, and so had a lot of good support with me. But I remember discussing with our trauma surgeon about how to lead the conversation. And it basically came down to, I'm happy to let you lead the talk, or if you want me to do it, I'm fine with that as well. And all this being said, deep inside, it had an emotional effect. And I was thinking about kind of the words and how I was going to get those words out of my brain to try to help this family come to terms with what happened. And we are getting ready to go in, and I remember I looked over at our trauma surgeon. I said, I just don't know if I can do this. I don't know if I can um, talk to this family about what just happened and what the next steps are. And being as great as she is, she said that's fine. I'm happy to lead the discussion and talk with the family. And it was, I and I felt bad, not only because of the situation, but I felt to kind of put it bluntly, I felt like a coward, because it's our job to not only provide the medical care, but also discuss what happens in the ER with these families, and they deserve to know that information. And I just couldn't answer the call when it came to that discussion. And we, of course, went into the room, and the family, they're very tearful, but still, you can tell there was still that little bit of hope that they were clinging on to. And we began the conversation, and of course, once we informed them of the outcome, they were very, very devastated. Lots of emotions in that room, lots of reactions. But I remember that mom, whenever we had finished, she had nothing but gratitude for what we had done, what they had done at the other hospital, and the things that we had done at our hospital. She was so grateful for the effort and the level of care we were able to provide, which is, a reaction that we see sometimes, but not often. But it just resonated with me that, you know, I couldn't help her get to that point of acceptance with my own words. But ultimately she was able to make peace with that. Maybe not then and there, but going forward, just getting that news, getting that final, "This is the end, your baby has died," allowed her to at least take those first steps. And after that conversation, I looked back and I said, like, "Why could I not do that?" Why is that something that was so difficult for me, as a provider, when I, at that point, had already been involved with lots of code blues, lots of unfortunate outcomes with patients in the past. And it was, it was something that allowed me to challenge myself, and work on those skills that we aren't really taught that well in medical school. We are taught the foundational medicine and the science, and what drug does this and what reaction does that, and the pathophysiology. But when it comes to just talking with people,
Yeah.
that is a skill that you have to just be able to develop on your own. And there are lots of people that can help with that. And you could always do simulations, but nothing's ever like the real thing. And that has allowed me to become not better at it, but more comfortable with delivering that type of news. And it's just such an intricate bond that you have with the family at that moment, that allows you to not only help them accept what has happened, but also accept, what you did or what you have tried to do, knowing that I'm not a failure. This is something that happens. This is nothing that I need to take personally. It's just one of those things that, um, I just have to learn and grow from and develop from. And I do think that case in particular, because it'll always stick out in my mind, I do think that case has helped me grow as a physician. It helped me grow and finish fellowship, and I think it has played a major role during my time as an attending, in not situations similar to that particular case, but other difficult cases that I've had to deal with in our emergency department.
Well, I'd like to uh, thank you, by the way, for that story. It really moved me, and it's funny when you first started talking about the story. It was a little bit um, foggy to me, but then as you expressed the details, I have a distinct memory of the child having a cardiac arrest and a CT scanner. I want to talk a little bit about some of the medical side of things, and then I want to talk about um, the emotional side of things and what you just described. What I have found uh, over the course of my career, and we've talked about this with other scenarios and other stories on this podcast, is that oftentimes in these horrific situations, which I call impossible situations, because the child is either going to die in the emergency department or comes to us dead, or we get the child to the ICU and the child dies, which is just tragic. Anytime a child dies, especially unexpectedly, in this case was even more difficult because the child was an infant. But if you think about it, this child had a lethal injury from the onset, and lethal head injury. Because when a child has a head injury and you said the child needs pressors, which for those of you who are not medical, those are medications like epinephrine or adrenaline that we give to actually maintain blood pressure and maintain life to avoid shock. And that's usually a very bad outcome, let alone what the neurologic findings may be in a case. But when you take a real meta view of this case, I've come to the conclusion that the most important thing that happened in this case was your conversation with that mother. It wasn't the medical care. And maybe there were things that could have been done, although I seem to remember this went very well from our standpoint, from a procedural standpoint. What are your thoughts about that? Do you think when you look back at it that your conversation may have been the most important thing that you did as someone who was very involved in the resuscitation?
Absolutely. As a matter of fact, the neurosurgeon that was involved in the case, we were able to get a very small section of the CT. And it was then when the baby began to deteriorate. But our neurosurgeon was able to look at the CT and said this is a non-survivable injury. There's no amount of heroic effort in the OR anywhere that's going to save this infant's life. And so once I heard that, it from a medical standpoint, it allowed me to come to terms with it a little bit better, knowing that there's absolutely nothing we could have done. So then it shifts towards what you're alluding to, the conversation with the family and what am I going to give this family with my words and my body language and my actions that are going to allow them to accept this and be able to uh you know go home knowing that this this is this is just an accident, and it's not their fault, it's not anyone's fault, it's just one of those freak tragedies that we often see. And so it really kind of boils down to, like how am I gonna allow this mom to start that grieving process and help her in these very, very delicate moments, because the emotions are very raw. And, we've seen people, become hysterical, appropriately hysterical. We've seen people become violent. We've seen people, just go into shock, expressionless. And I never judge emotions when it comes to these situations. I never judge how a person reacts because it, it's it's a tragedy, and human emotions are very real in these situations, and you just have to process them. And if there's a specific way that allows you to do that, we will enable you, help you process that the best way we know how. And so that conversation is just so critical. And it's sometimes very difficult to just find the right words. But I found that if you're very direct, but um, you're very sensitive with your words, but also very direct, because that's the buzzword they're waiting for is my kid alive? Have they died? Once they hear that word, then that process starts.
What is the calculus around taking an unstable child that's we have these trauma bays at Arkansas Children, and very large rooms where 30 or 40 people could fit in, a little tight, but many specialists can be in the room. And if I seem to remember correctly, in this room, we not only had the Pediatric Emergency Medicine team, which was you, myself, maybe a resident, and then we had trauma surgeon and 2 or 3 trauma folks, and then maybe anesthesia, respiratory therapy, and a neurosurgeon. So we're in this big room. We're managing a very sick child that's there. Can you talk a little bit about the calculus of going to the CT scan? Because no one wants to go to in the middle of a hallway or go to another area of the hospital and have a child's heart stop. So can you talk a little bit about the calculus around that? And I don't know if you remember specifically in this case, but it is a little bit of a calculus in terms of the risk and benefit.
You know, essentially you're going from a bigger space to a much smaller space with a lot more obstacles, a lot more things that can impede your ability to deliver resuscitative efforts. Our CT scanner at Arkansas Children's Hospital is about, she was in room two. So about 20 yards from where the resuscitation bay is, for where she was actually located. But based on how critical this baby was, even just a 20-yard journey was going to be a huge undertaking because you are leaving the confines of a trauma bay where you have equipment, you have medications, you have supplies that you can use to further stabilize the infant. And you're going into a room that has a scanner, and has a couple of things, for oxygenation, being able to deliver the baby oxygen or a couple of other things. But, you kind of get outside your toolbox a little bit. You kind of have a lot of your toys taken away from you. And, being a smaller confined space, it's really hard for the right people to get access to that baby. The baby was already intubated, already had a breathing tube placed at the outside hospital, but respiratory therapy, I remember, was having a very difficult time being able to get to that to deliver ventilations, breaths during our resuscitation. And even though we had to pull the baby out of the CT scanner, we still could not go back. We had to do it right then and there because time is precious when it comes to a cardiac arrest event. And I remember
And
that.
what you're talking about there is starting CPR
Yes,
essentially, and making sure that we're we're assisting pumping blood to the rest of the body.
yes, yes. I I remember that the trauma surgeon even did bilateral decompressive thoracotomies, which means basically taking an instrument, inserting into the chest wall to relieve any type of free air that's trapping the lungs or any blood that may have accumulated to hopefully take the pressure off of the heart, to allow it to start beating again and respond to the medications that we're giving and the CPR that we're delivering. I mean, every single thing that we could have possibly thought of was done in this situation. But it was very difficult because of the logistics of just having a smaller space to be able to do this. This was a smaller patient, but when you have almost 15, maybe 16 people in the room with you, it's just very, very difficult to be able to kind of delegate tasks and know exactly what everybody's doing. And so it was very difficult, just based on traveling from that 20-yard journey from the trauma bay to the CT scanner. It was a very difficult resuscitation just from a logistics standpoint.
And yet it's really important to get a child to the CT scanner, because one of the things that we didn't know until the child did get a CT of the head is whether the injury is lethal or not lethal. In other words, the child would succumb to the injury. And then if it's non-lethal, the other question is this an operable
Hmm.
injury where the child can be taken to the OR and something positive could happen from a craniotomy and opening up uh, the brain to uh, evacuate blood or whatever needs to be done. And so there is this calculus that you're trying to stabilize the child and the trauma baby. You're also trying to get them out to that next step. And with head injuries, this is sort of the challenge that we have. You had used the word, which I thought was a pretty strong word, when you were describing the moments before coming into talking to the family. And by the way, this it's incredibly vulnerable of you, Patrick, to bring this story up, because these, I think, are some of the most horrific and challenging cases for us on a personal level, on a human level. And you use the word coward, which is interesting to me, because I thought what you described was the exact opposite. That I thought that you were courageous to be able to um, do something that you don't get a lot of exposure to or experience as a resident, and sometimes as a fellow. These are rare circumstances, but when they happen, you need to do it as the attending and be there. So what was making you sense or having a feeling of cowardice? Because I see it as courageous, but I'm curious what your thoughts were about that.
Yeah, you know, this case, the way our fellowship works, at Arkansas Children's Hospital, I remember I was a third year fellow, and so at that point of your training, you should be pretty familiar with running a resuscitation or running a code, being able to direct CPR, and Dr. Spiro here graciously allowed me to take lead on this case from the medical side of things, and so I was able to run the code and work with my team and kind of quarterback how the resuscitation went. And once we had reached our endpoint, once the baby had been pronounced, that part's over. Everything has come to an end with the medical side of things, and so now it becomes the aftermath. And you know, the way my brain was kind of processing this was, okay, I was the leader on this, and I was the one communicating with neurosurgery and trauma surgery and our respiratory therapy and nursing staff and anesthesia and everybody. Um, I need to be the one that, as a leader, I need to be the one that facilitates this conversation, with this family. And I'll always say I'm my own biggest critic, because like I'm intentionally hard on myself because that is how I get better in this craft, but not to a point where it's detrimental to my growth. But just I just want to make sure that I'm doing the best I can, and in that moment, and I really can't put a finger on what was going on in my head. Like this is something you've seen before, maybe not to this extent, but you've seen death in the emergency department. You've talked with families, um, because yeah, for these outcomes, you have had these conversations in the past, and I just don't know if it was the baby's age. Maybe it was literally a week before Christmas. There was just so much that was just bouncing around in my brain, and I feel like the tidal wave kind of just consumed me a little bit. The tidal wave of emotions, and because I did not lead that conversation and share the first words with the family. I felt like I kind of withdrew a little bit into myself, because just of how that impacted me from an emotional perspective. And looking back, and not to say that I have regrets for not being able to do that, because I do think it benefited me from having to experience that, just being able to carry future conversations that I've had since that time. But it's just one of those things where it's scary. It's
Oh,
so scary to face a family that just had a major devastating traumatic event happen to that family, brand new baby, And thinking about this, the 4-year-old child that was in the room that watched this happen, the level of impact it's going to have on him growing up, having witnessed that, just all those things. And I just kind of succumbed to my fear and my emotion a little bit with that conversation.
So, can you talk a little bit? I didn't mention this in the introduction, but you have an expertise in wilderness medicine, which is phenomenally interesting. And can you talk a little bit? We see, unfortunately, a lot of dog bites, and so sometimes when these events happen, which are horrific, um, we also want to prevent them from happening. So, could this event have been prevented? So many of us have dogs. I've got a little dachshund beagle mix, and we love her very much. But what are the risk factors for these kind of things to actually? We're not in necessarily in the world, although we do some of it in terms of preventive health and education. What um, what are the learnings around dog bites, and how can we prevent them from happening?
I'm so glad you brought this up because this is something I was actually thinking of, and I've thought of since that day. You know, social media is a great tool. It's a great thing to have. But one thing that kind of um, catches my breath a little bit when I look on the social media is when I see families with an infant or a toddler and a dog that, basically putting them on the dog when the dog is lying on the ground, or allowing the dog, to lick a baby's face or something along those lines. That in and of itself is a risk factor because that is, as domesticated as that animal may be, that is still an animal. And there are specific things that trigger animals. With the husky that bit this baby, I don't know, we'll never know, what actually triggered this dog to attack this child. Did the baby make a noise? Did the 4-year-old throw a toy in that direction? We'll never know. But just seeing those videos, those pictures of parents placing their child next to these huge dogs, even small dogs too. Small dogs can do major damage. And I'm very much a dog person. I grew up with huge dogs. We let them roam about our land growing up in Southwest Mississippi, and they never attacked us. They were always very friendly. But even the ones that you trust the most still have potential to cause injury. And so, kind of a big take home point from this is just be careful with your children around your animals, especially dogs. It's just you just never know when that day is going to come, where that dog does something unexpected, and so you have to respect the fact that this is an animal, and animals can do unexpected things sometimes, as we see often in the austere environment. They teach us the medical side of things, but also they teach us respect, respect for nature and respect for the wilderness. You see a cute, little bear cub out in the woods, don't go anywhere near it because mama bear is not far behind. And so, you just have to be mindful of, just the fact that this is an animal that you can't, they can't talk to you. It only reacts, it only processes what's going on in its environment. And so, just be very, very careful to all parents out there. The videos are very cute. It's very cute to see your brand new baby next to your Australian Shepherd or your Golden Retriever, but that you are taking a risk with that when you put them in those situations. And I will preach that message to the day I die. after
Um,
after that case we had, that will forever be ingrained in my brain.
so, with your experience in wilderness medicine, just as we're wrapping up here, Patrick also spent time, one of a small number of Americans that had an opportunity to go visit Mount Everest in Nepal. Related to this story, do you have any comment about every cultures treat dogs differently? And
Mhm.
did you see a lot of wild dogs roaming the street in Kathmandu? Were they up at the base camp? What was the role of dogs, and how were they treated in Nepal? Did you make any observations while you were there?
Yes, I was actually
Interesting.
very, very surprised at how many dogs there were, not only in Kathmandu, but also on the mountain. We actually had one dog that hiked with us for about 7 miles one day and followed us up to
Stray
our
dog,
tallest, yeah,
a
stray
stray dog.
dog. Yeah. And the way the people of Nepal they treat animals, they're kind of just there. It's almost like a stranger, like a person. Just kind of if you're on the busy streets of New York and you're walking by and there's a person coming, down the sidewalk. I mean, that's kind of how they treat them. And these dogs just they roam from city to city. Um, and we even had one follow us up to the tallest peak that we hiked to, 18,500 feet, and just took a nap on top of the mountain. They're just so used to being around people, but I don't think anyone owns these dogs. I think they're just there, just to exist and be there. And the people, they leave food out for them, and they're kind of just part of the culture. But I did ask specifically to ask our guide, and I asked some of the locals that were hiking with us. Do you guys ever get a lot of dog bites from all these stray dogs running around? They say, no, we really, really don't. They kind of keep to themselves. And I think they do a really good job of telling their children, don't pet every single dog you see on the trail because, these kids have to hike miles to go to school, miles to get to a clinic, to see their, primary care provider when there's only two clinics on the mountain. And so they pass by these dogs all the time, but I think the parents do a very good job of teaching them that level of respect. Like, don't pet every dog that you see. You never know what might happen. But surprisingly, with as many dogs that as there were in Nepal, not a lot of dog bites. More here, statistically compared to a place like that, which was very surprising to me.
Yeah, and rabies counts are quite low in the U.S., but unfortunately, out in the developing world, if you get bit by a dog, you need to correct me if I'm wrong. You're the expert, but there's a concern for a higher risk of rabies, and in the developing world because a preponderance of domestic dogs in the U.S., the vast majority are immunized and vaccinated. Is that true?
Yeah, it's there's not a vet. 15,000 feet in altitude on the mountain. And so they do carry both the rabies immunoglobulin and the rabies vaccine, but very, very, very limited supply. It may take two patients to completely deplete their stock, just because they have to have all these medications and all these vaccines flown in from Kathmandu, from the capital city, and there's no routine delivery schedule. It's not like your HelloFresh box is going to be delivered next week on a Tuesday. You may not get a shipment in until a month later. And so there's a big risk with that. If you deplete your stock, then, what else do you do other than you have to try to get the child to Kathmandu, to the major hospital there, which is a huge undertaking because of resources and funding. And so, yeah, it's a very, very delicate situation over there, based on kind of just how limited they are, with what they can provide from a medical standpoint.
Well, Dr. Patrick Ayers, it has been a pleasure to have you on the show today. And I believe it's Yiddish. We talked about this with David Shapiro on a previous episode. There's a word that we use. It's called mensch, mensch, which is a good soul. And you are a good soul, my friend. And I
Thank you.
am really honored to work with you, to have been part of your training. This story, it just makes me realize how lucky we are to have you at Children's, and providing care for the children that we serve. So I want to have you back on the show because I know that you have a story to tell from your experience going to Everest. And I want the audience to hear about that because that's very unusual. And I would love to have you back on and talk a little bit about your interest in wilderness medicine and how you've been pursuing that as a subspecialty within a subspecialty. So.
Absolutely. It's one of my favorite stories to tell. So I am happy to come back anytime you want me on, Dr. Spiro. Yep, happy to do it.
Well, we've got 13,000 subscribers, and hopefully when you come, I know it's incredible. We
That's
had
great.
1,000
That's
a month
great.
ago, and now it's just growing, and we're really excited about that. And so for everyone that is joining us today, please hit subscribe down on the YouTube button or Apple Podcast, Spotify, wherever you get your podcast information. This is Dr. David Spiro for HUMED, Human Medicine, signing off, and hope you all have a great rest of the day.
Thanks for listening to HUMED with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.